Good morning, everyone. The Health Quality Council is proud to be a partner investor in the Wîcihitowin Conference, and to use words I heard earlier that have really resonated with me this morning, happy to be here in the spirit of working together to help each other. I'm very honored to be able to introduce our plenary speaker this morning, Dr. Alika Lafontaine. Dr. Lafontaine is an award-winning physician, speaker, alignment consultant, and the first Indigenous physician listed by the Medical Post as one of Canada's 50 most powerful doctors. A strong believer in the design thinking approach to unlayering and addressing intractable problems, he has participated in local, provincial, and national projects to move forward health systems change. After completing a Bachelor of Science in Chemistry at the University of Regina, he completed his MD at the University of Saskatchewan, followed by a 5-year fellowship in anesthesiology. In the midst of his fellowship, Dr. Lafontaine became CBC's Canada's Next Great Prime Minister, winning the competition with a platform focused on reconciling the treaty relationship between Canada's Indigenous peoples and Canadians. In addition to other awards and honors, Dr. Lafontaine remains the youngest recipient of the Inspire Award, the highest honor Aboriginal peoples give to their own for the past 20 years. And in 2015, he was selected as a recipient of the Canadian Medical Association Young Leaders Award. It is my honor and pleasure to welcome Dr. Lafontaine to the stage to provide his plenary address. Please join me in welcoming Dr. Alika Lafontaine.
So it's great to be back. Tansei, Bozo, Tashi, good morning. I'm Alika Lafontaine. I grew up in Regina and I went to school here, so I'm Saskatchewan grown, but like many exports, I went to Alberta, and I've been living there for about 10 years. During the opening address, when Walter was saying some words through the presentation and through his family, I thought about my time here in Saskatchewan. And I don't tell this to many people, but I was the first Indigenous person to get into the College of Medicine for about 4 years. So I was by myself for most of med school. But I have both really bad and really good memories from here. 2 weeks into med school, I ended up writing an exam. I think it was microbiology or histology, and I got a 70. And I mean, for a med student, that's like really bad, right? And I was sitting there freaking out with a lot of my classmates, and we're all trying to be supportive, and they said, go talk to the professor. So I went in and talked to the professor, and I remember walking in and saying, you know, I don't feel very good about how I did on this test. I was wondering if I could spend a bit more time learning and maybe getting some tutoring. And what she said to me was, you know, if you fail first year medicine, it's not the end of the world. And then she motioned me out of the room. And in that moment, the high that I was on in the first 2 weeks of getting into medicine completely shattered. And I remember walking out, and I was walking down the hall, and I was thinking to myself, you know, I shouldn't be here. I don't have any family who's gone into medicine. I don't know anyone here. I want to go back home. And I ran into Val Arnaud-Pelche. A lot of you probably know Val. She sat me down and she said, Alika, you don't look too good. And we had a talk, and I felt better, and I started walking away, and I ran to the dean, who was William Albert. And every week for the next 4 years, I sat down with Val or with Bill, and they reminded me that I belonged there. And so when I hear words like safe space, something that Walter really advocated for, it was that safe space that made me think that things that I didn't think were possible were possible. And I can tell you that if I did not have those weekly meetings with Val and Bill, I wouldn't have finished med school. I would have never applied for residency. I would have gone home. I probably would have been happy. I would have been with my family. But all these other opportunities would have passed me by. And so whenever I come back to Saskatchewan, it's a reminder of where I've gone, but it's also a reminder of where I've been. And for those who haven't gone through these experiences, who are trying to access reconciliation from the other side as a non-Indigenous person, even those of us who seem like we have really thick armor, at the end, all of it gets stripped away at one point. And we need those safe spaces. We need those safe spaces to feel like we can be open. And even 20 years, it was 2002 that I entered into med school. Even then, even now, I sit there and I think about how I felt, and I'm taken right back to that day where I felt really, really small. I'm so excited to be here, to look across the crowd and see people who really want to try and understand each other. You know, when I first started out med school, you couldn't say words like racism. You couldn't talk about power differentials, oppression, residential schools. You know, everyone thought that you were this special case who had all of your school paid for, that got in through some program where you weren't qualified to be where you were supposed to be. But having this space, this safe space in this room, is something that I'm really, really proud to be a part of. So I'm OG Cree, I'm Pacific Islander, I also have Métis ancestry. I've been co-designing and leading Indigenous health projects and health transformation projects for the last couple of decades. I have a bunch of fancy titles, I won't go into those. There's a few things that I want to try and get through in this presentation. I'm going to talk a bit about equality, equity, and justice in healthcare. So I think we're at a place where we really need to start integrating this across everything that we try and do. I'm going to talk about a world that we don't see, talk a bit about truth and reconciliation when it comes to health, touch on why patient experience is really the beginning of change, not the end, and some practical advice from my couple of decades of experience of how you can actually implement some of these things in these systems. I'm just going to talk briefly about the Indigenous Health Alliance. This was a project that actually started here in Saskatchewan with 3 First Nations, Key, Cody, and Kisakus. The project eventually spread and expanded to include political leadership for more than 150 First Nations. We had 24 national medical organizations involved. The federal government was involved. And what we're really trying to do is bring forward this message of health transformation, which in the end came down to safety, quality improvement, and patient-centered care. At the end of the project, after 4 years of working with communities across the country, the government allocated $68 million for projects related to health transformation. And some of the things that I'm going to touch on are things that we learned over those 4 years and how we actually helped the government see that it needed to walk in a different way. So equality and equity is kind of where we start our discussion. When we first started talking about equality, we really talked about having things the same. The problem with having things the same is that a lot of times we don't start off in the same position. So even though you may get the same opportunity, have the same access, you need more to get the same outcomes. So after we talked about equality, we shifted into equity in health. And equity was about fairness, making sure that people get access to the same opportunities, but that we give them a little bit of extra support. Where we really move the discussion now is into justice. And it's talking about systemic reasons why inequities and differentials in outcomes exist within healthcare. And it's removing those barriers. You know, one example that came out from the 3 communities that started off the Alliance was that they had the highest apprehension rate of children in the entire province. And as we kind of went through the reasons, one of the things we realized is that the methadone clinic that was close by was one of the reasons why children were apprehended. So at the time, if you were on methadone, your child was immediately apprehended. They didn't do an assessment of your family. They didn't ask you whether or not at what point in the treatment you were at, whether or not it was a safe space for the children to learn and grow and develop. They just took your children. And so on one hand, we were communicating to the three communities that, you should move on to methadone as a path to healing. But on the other hand, there was a policy that if you went on this path, your children were immediately taken away. And so justice is removing that barrier, changing that policy, making sure that when we tell people that they're accessing things, that they're actually getting everything that they need. The Institute for Health Improvement is an organization that's probably known to a lot of health people, not necessarily to a lot of people that are outside of health, but the quality improvement movement was really started in the late 90s by this organization when they made a challenge to a major medical organization to save 100,000 lives in the next 8 months. And that launched the health quality improvement movement. Many people think that institutional change, transformational change, takes a long time. In reality, transformation actually doesn't take time at all. I still remember being in training, us using multiple syringes on different patients in order to conserve medication. One day we decided that that was no longer what we were supposed to do, and everybody stopped. That safety change took a single day. All right? Recently, we made a change over to one-use instruments within the operating rooms across Alberta. That change took a week. All right? Quality improvement hasn't been around for a long time. It's only been around since the 90s. It spread across the entire health system within the next 6 or 7 years, from 1998 to 2006, 2007. Transformation does not take a long time. And if you're looking to achieve transformational change, that's one of the markers of whether or not you're actually in transformation or not. It's a pretty straightforward concept, equity, equality, and justice, but it's very difficult to implement. There's a concept here that I'm going to introduce to you called scotoma. So in medical school, we learn about this term, and it's pretty much talking about a blind spot. So these blind spots exist for a lot of different reasons. Maybe you were born with a blind spot, maybe you developed some type of neurodegenerative disease, maybe you had some sort of trauma to your eye. But for whatever reason, you can't see what's right in front of you. So I'm going to go through a little exercise here, and I'm going to ask you to count Fs, okay? Anyone who's gone through this exercise before, don't shout out the answers, and maybe just raise your hands when I ask you questions here. But there's going to be a paragraph. I'm going to have you count the Fs, okay? So here we go. So I'm going to give you 3 seconds. 1, 2, 3. So how many people saw 3 Fs? Raise your hands. Okay. How many people saw 4 Fs? How many people saw more than 4? How many people were afraid to raise their hands? So I would say, based on the people who participated, the mix is probably about what I see across the country. So I presented this hundreds of times. About half of the room usually says that they see 3 Fs. About 25 to 30% say that they saw 4 Fs, and then the remainder see more than 4. So there's actually 6. So finished files are the result of years of scientific study combined with the experience of years. All right? So why didn't you see the Fs? So one of the things that we do when we read paragraphs is we read in our heads, right? And so the sounds of scientific don't line up with the sound of, right? So that's one of the big reasons. The second is that we read for content. So even though I told you guys to read the Fs, a lot of you were probably trying to figure out what the paragraph was about, right? The third is that we skim to be efficient. I didn't give you a lot of time to read, and so you were focused on the big words, not the small words. So now I'm going to have you read some triangles, okay? So just read them 1, 2, 3. So here we go. Read number 1, read number 2, and read number 3. So now I want you to read them again. So how many of you missed the double words? So I literally just told you what was going to happen. I told you the reasons why. I told you what to expect. but you still did it. These blind spots are incredibly powerful. And they're a big reason why we can't see or perceive distortions in our understanding, why we can't achieve truth and reconciliation between each other. You know, one of the groups that this never works on is kids who are below grade 4, or people who never went on to finish grade 4. For whatever reason, between grade 4 and 5, you develop these rules in your head about how to read. And if you don't ever get exposed to these rules, you can't be tricked in the same way. Reconciliation is about revealing what these rules are. But what else don't we see?
Yes, I have experienced racism analysis with the doctor here and nurses. You know, nurses treat us differently. My file, every time I go there, like, I'd be there before everybody, and I thought it's first come, first serve. But my thing would my file would get put to the bottom. You know, I'd have to wait there all day, and I'd be trying to talk to one of the nurses, or talk to the doctor. Then they'd tell me, go sit down, like telling me to go sit down like a child. I'm not a child, and then not wanting to speak to me, and then I see someone goes up right after me, like another patient, and they talk to one of them right away, and like they tell me they're busy, and that's with the doctor and nurses that they do that. Well, for one thing, I'd like a different doctor, plain and simple, a different doctor, and also better training for people skills for the nurses. They seem not to have any people skills, They get grouchy at us. The woman that sits at the desk that takes some names and, sets us up, she gets grouchy with us. When I was there 2 weeks ago, I heard her swear and say effing natives. I heard that. I was sitting right there in that chair. She kind of whispered it, but I heard it. I heard it clear enough to make out effing natives.
Well, I know when my mother was in the hospital, she had diabetes and she had, like I said, heart, kidney, and lung problems, and she was in the hospital for about a month or maybe even 2 months. And when I went to visit her, she didn't have no sheets on her bed. They told me that she was on a mattress that didn't need sheets, but when they finally came to check on her, it was not that kind of mattress. And my mother wouldn't say anything. She wouldn't make any kind of fuss. She just laid on the rubber mattress, and that's it.
I'm a diabetic, and the one you're talking about, he likes touching women. He even done that to me too. And I used to wonder, is that possible for a dog to do that? Eh? He slipped his 2 hands into my panties, but didn't touch my private. He done that from the back to the front. Eh? Boy, I was amazed, and he just threw himself on the chair after he done that, and he was just blushing, just red. Eh? I just about swore at him, but then again he might charge me. I should have swore at him at the time. I tell him the same thing what I experienced with him. Are they going to do anything about it? Like that. You know the time I broke my knee? And then when I was there for 5 days, and the nurse was coming to give me 4s. And then I told her, can I get a Tylenol extra strength instead of it? She got mad at me, and she went back to that word she keeps her pills to come and give me that Tylenol. And she holds my lips and then puts that pill into my mouth roughly. And I told the other nurse to put my leg on that pillow. She lifted my leg, put that pillow there, and just dropped my leg. I was just being treated. If I was able to walk, I said I would have walked out of there. And I told my auntie, though, she gets the same treatment.
a lot of old elders don't feel safe there. Like, you know, from I was like, you know, I see elders when they're in a hospital, like when I go up there from my town, I talk with them. You know, they don't feel safe. They look scared, but they don't want to say anything, but they look scared, and you can feel that on them. You know, and that shouldn't be these are our elders. You know, they shouldn't be feeling scared like that. That's a place they should feel safe.
Kinds of things should happen. We should have proper diagnosis. We should have First Nation people at the doctor's office, the drugstore, throughout the system there. We should have a place for concerns to be heard, anonymity, and also online questionnaires or something to that effect where a person can actually just sign in and say this is what happened to them.
He's the only doctor we can see, so like what if we're really sick one time and he doesn't want to give us treatment because of that? And he will do that.
And that nurse there, that receptionist at the hospital, she used to be very friendly with me. Now I'm mad to her, I guess. For what, I don't know. You should see the way she treats them, eh? Very negative and looking angry. I just about told her the last time, why don't you quit your job if you don't like working for Indians? I will do one of these days.
Those aren't easy stories to hear. And even after sharing those stories over and over again, it's still hard for me to hear those stories. I'm not suggesting people within the health system go into work hoping to harm Indigenous patients. Like, I don't think there's people out there who are like, you know, if I just harm 3 Indigenous patients, it'll just totally make my day. But in reality, that literally happens. And one of the things that I've come across over and over again in my work is that we don't acknowledge that this is the common experience. You know, it's an interesting perspective being here on stage watching people watch this video. Because you can tell people who've gone through these experiences. You can see it in their faces as they acknowledge what they went through. You know, I'll share an experience that happened to a family member. I was on call one night and I got this frantic call from this family member, and they said, you know, I'm in emergency and I've been doubled over in pain. I don't know what's going on. And they start describing their symptoms, and I'm like, oh, that's appendicitis. And my family member goes, well, you're an anesthesiologist, Alika. Do you really know what appendicitis is? And I'm like, come on, man, everybody knows what appendicitis is. So yeah, family does not take you seriously, even if you're a doctor. So we're going through the discussion, and I'm telling him what to watch for, and he's kind of half believing me, half not, and ends up going in to get assessed. And I got a call back, and they're like, well, you were wrong. It's actually kidney stones. I said, kidney stones? This doesn't fit kidney stones at all. And so I started to ask what they actually did. And they asked a few questions. They never did a physical exam. They never sent off for blood work. They never did an ultrasound or a CT. And they told them that it was kidney stones. And I, of course, am sitting here thinking to myself, this can be really, really serious. And so, luckily, I trained in the place that he was getting care, and I phoned the head of surgery just through switchboard. And he remembered me because his car started on fire during my rotation there. That's a different story. But he picks up, and he's like, oh, hey, how's it going? You know, how you been? I said, oh, sorry to bother you, but, you know, my family member's down in Emerge, and I really hope that you're around so you could go see him. And they go, well, I'm not around, but I'll talk to this person who's on call, and they'll go down and see him. Don't worry about it. So anyways, the surgeon comes down, does an assessment, and sends him off for imaging, and we find out that his appendix ruptured. Rushes off to emergency surgery. And I remember talking after the surgery, and one of the things that they shared was a frustration that even though they'd gone on for higher education, donated to their community, was a pillar of charitable things that went on, and well known. He said at the end, you know, when I put on that gown, I'm just another Indian. And this is the experience of Indigenous patients who are in our healthcare system. Is it doesn't matter who we are, it doesn't matter what we've done. At the end of it, we strip away every one of those layers of privilege, and I have lots of privilege, like don't get me wrong. I'm a physician, I'm a man, I have college degrees, I have titles, I'm tall, I look like security, like there's all these different things. They actually used to call me big guy in Saskatoon because I was security. But you lose all those things once you enter into the doors of a hospital. And these are the things that we need to talk about if we're really going to have truth before we have reconciliation. Our stories are so out of norm and removed from others' experience that those others have a hard time believing that these things could happen. They believe these experiences are extremes. This is our status quo. For those of us that live this reality, the status quo is no longer an option for us, our children, and our communities. So the question that I ask to everyone here is, when you hear these stories, do you believe them? And then moving from there, do decision makers within the areas that you can have impact, do they believe these stories? And then finally, do we share these stories openly? I used to talk about bias and racism and discrimination, but I think when we talk about what we believe about Indigenous patients, what we're trained to believe about Indigenous patients, through modeling, through words that we hear, through charts that we read, you know, the person who's on the methadone program because they were dealing with their trauma by turning to some sort of street drug, turn their life around in college and other things, when you read in their chart, oh, this is a difficult patient. That's a trigger. That's me saying I should make sure that this patient is employed. I should make sure that they understand what we're talking about. If they're between jobs or they seem like they don't understand, then I should just write them off. You know, they don't want to help themselves. Why would I want to help them? You know, I remember when news first broke about forced sterilizations. And I know that this is a very sensitive subject, but I'll say it's not a sensitive subject because people don't want to talk about it. It's a sensitive subject because of risk. It is risky to talk to people about problems that happen in the health system because of litigation, reputational issues, operational issues. If you have someone who consistently causes harm to patients and they're an important part of the system, what do you do if they're gone? Right? It took me 9 years to get trained as an anesthesiologist. Let's say that we identified every person who had racist tendencies who was in anesthesia and then got rid of them. How would you bring back the people who serve in that capacity? So these are real risks that don't just affect the system, but impact our care too. But I remember reading some of those stories, and I'm pretty convinced I sat in on those cases during my training. And I didn't have that context until I was out in practice, and I realized that a lot of the things that I thought were normal weren't normal. You know, we usually do C-sections under spinal anesthetic, so the patient's awake. And so when a mom would cry during the tubal sterilization part, one of the things that we always talked about is, well, maybe the spinal isn't high enough, you know? Maybe it's not covering that area of pain. I can tell you spinals almost always cover tubal clippings, right? This is after 9 years of experience. I didn't have any of that context as a trainee. And so when a mom would cry, when she'd ask me to hold her hand, I sat there and thought to myself, I need to use a higher dose of medication next time. Maybe I should provide some sedation to make it more comfortable. Maybe she's just anxious. But it never crossed my mind that we were taking away her ability to have children without informed consent. And so even in talking about it, and I have talked about racism, bias, and discrimination for 2 decades, even myself did not see what I had learned not to see. And so when we enter into these conversations, when we enter into these conversations, we have to be sensitive with each other and realize where we're all starting. One of the things that we learned from the Alliance is that system change, it always starts with belief. It's figuring out what it is that people believe. And those beliefs impact behavior. All right? But in order to impact behavior, we have to ask the question of what systems believe about Indigenous patients. For behavior to have impact, to actually change outcomes, to have a strong enough change that you challenge your own beliefs and start to think differently, you have to start to figure out what are the outward manifestations of this behavior. But as part of that, you have to keep in mind that sometimes it actually makes a lot of sense why things exist the way that they do. I'm not saying that it's just, I'm not saying that it's right, just that it makes sense. If I train around people who label individuals who are homeless and addicted to drugs as a high risk for opioid abuse, it makes sense that I don't give them narcotics in hospitals. Is that best patient care? Absolutely not. Is that right? Absolutely not. But when we're creating our starting point for sharing truth and creating these safe spaces, we have to figure out in our heads, how can this make sense? Not that it's right, but how can it make sense in that other person's context? As we move from behavior having impact to actually having that impact, we have to be really clear on what we want to achieve. And one of the questions that we asked in the Alliance over and over again is, do these behaviors affect access to inherent and treaty rights? All right, so one of the things that we learned through our work was that treaty rights are actually a tricky way to get rid of other rights that you have inherently. By definition, treaty rights are negotiated between 2 parties. But if you can negotiate everything, you can also negotiate nothing. But in reality, your rights to health don't just come from treaty. They don't even come from being a Canadian citizen. They come from being in Canada. An immigrant, someone who's in the process of obtaining their citizenship, they have Canadian rights to privacy. They have Canadian rights to make sure that they can make their own decisions, which we call patient autonomy. They have a right to expect certain standards of care from people, that the person sitting across the table from you or with you in the operating room actually has the skills and abilities to do what they said they can do. These are things that you don't have to negotiate for. These are things you already have, but that we've negotiated away in our treaty conversations because of this false belief that we've inherited through colonization, that we don't have access to these rights. And let me underscore, this has nothing to do with being a Canadian citizen. We can be our own nations. We can be our own communities. We don't have to identify as Canadians to access these rights. There's also certain standards that exist from just being in a province. Access to certain types of services. But what happens a lot of times is we mix together different asks. Asking the health system to provide someone who can diagnose diabetes and provide medication is very different than asking for a dialysis machine. But how often do those asks get mixed together when we have discussions? And so we really have to untie and get clear on what we're trying to achieve. Whether or not we're asking for equality, equity, and justice, or whether we're negotiating for additional things which we do have access to through treaty rights. And the real question that the health system has always pushed back on, and the space that you can get into and be on pretty firm standing, is what you're asking reasonable? When we were working through the Alliance, we came up with a list of 5 things that we wanted to make sure that every community had. We wanted to make sure that diagnosis of common medical conditions was something that all communities had access to. Why is that reasonable? A logging company that's right beside a remote Indigenous community has access to a physician 24 hours a day, 7 days a week, required by law under the Health and Safety Act. And yet we commonly accept that having a doctor visit our community once a week, twice a month, is reasonable. It is not reasonable. The second thing was that you have access to actual medical treatments as a result of your diagnosis. Third was being able to treat common emergencies, things like asthma attacks, anaphylaxis, heart attacks. Fourth was making sure that information was transferred in a way that was private and confidential. How many of you share information with First Nation Inuit Health Branch that's of a medical nature, but it's not treated as a medical record? How many times do you sign on the dotted line in order to access treaty rights about medication that you're on, the reasons why you're on it, the history of your medical condition? You have a right to not provide that information. The first time that the Federal Privacy Commissioner ever ruled on a case in health was based on a privacy case that came out from Sioux Lookout in Northern Ontario. And what the federal government was demanding was that patients write down the diagnosis of what they had, as well as a little blurb about the history in order to access medication to non-insured health and benefits. They ruled that this was a violation of their rights to privacy. Keep in mind that the Federal Privacy Commissioner has never ruled in the history of the Federal Privacy Commissioner on issues in health. But how long did it take for that system to change, if it's changed? In the mainstream system, we pass laws and the next day they're enforced. In Indigenous systems, we pass laws or create new policy, and then we wait months for them to be implemented. That's neither reasonable or equitable. This is where rapid system change occurs. When we look at quality improvements, safety, patient-centered care, the reason why they spread like wildfire is because we started with beliefs, we looked at changing behavior, we made sure that those behaviors had impact, we were clear on what we were trying to achieve, and then we institutionalized the support of those behaviors. And we can use that same sort of approach in making sure that truth does actually lead to reconciliation. So how do we currently try and change things? So I'm sure we've all been a part of this. You organize a committee, that committee comes up with a series of things that they think they should do. You share that with community members. When you bring that back, you create a draft report. You then take the draft report and share it with everybody again. And then that becomes your final report. And then you go and you say, everyone should adopt these recommendations, right? And we're making a lot of assumptions here. But how often does this work? I've been a part of countless reports. I can tell you that the report itself rarely had any impact. So one of the closing points I'm going to make here is talking about actual system change and how you do it. And one of the things that came up over and over again in our research was moments and momentum. So moments and momentum often get mixed together. Moments are times when individuals rethink their beliefs. Momentum, on the other hand, is a scale up and scale out of behavior. If problems are complex, involve multiple stakeholders, and historically have been really, really difficult to change, you have to start with moments. Intuitively, as Indigenous people, we work this way. Framing our days around ceremony, framing our days around a person or an idea, having people share their stories. These are curated moments. We're inviting people to rethink what they're actually trying to achieve. But when we shift over to actually doing the work, what do we often do? Oh, well, what's best practices? Let's just drop that into there. Right? What have we always done? Well, let's do more of that. Moments really develop hope that change is possible. And one of the things that is consistent across Indigenous health, Indigenous education, Indigenous social service transformation that I've seen over the past couple of decades is that the conferences are always full of hope. You walk away believing that change is possible. The second part is creating that empathy and inclusion. All of those things together create trust. Trust is the ability to take risks with other people. And health transformation, it has a lot of risk. As a physician sitting here across from you, sharing experiences that I've had, even sharing the experience of me sitting in on tubal ligations that were likely without consent, that exposes me to risk. That exposes me to potential reputational harm. If I apply for a job here in Saskatchewan, that could affect those things. These are all theoretical risks. I'm not saying they're actually going to happen. But sharing these stories, they have risks. When patients share their stories, they have the risk of having the person deny them care. They have the risk of not being offered options. They have the risk of walking into a hostile environment. How many of you have walked into a doctor's office and immediately felt like the doctor was yelling at you? These are all the risks that patients take on when they share their stories. As trust decreases, risk gets worse. If we don't create hope, empathy, and inclusion, the risk gets worse all around. And that's the message that I share with health systems whenever I present, is that it may be uncomfortable for you to sit across the table from patients and hear their stories. It may be hard for you to hear the hard truths about what they're experiencing, but if you don't, things will actually be worse for everybody. Among stakeholders, if you carry the harm, you carry the risk. And our nations and communities have carried much greater harm than any other stakeholder group. This is why we have to be courageous in sharing our stories. The final slide that I'll share is just a quick note about control versus accountability. And this is something that came across in the Alliance that I think is an important message. These two processes, they're necessary. Neither is more important than the other. But if you don't have both, it's really hard for change to happen. Political processes are a negotiation over who controls resources. Transformation processes, on the other hand, are a question of who's accountable. And let me ask you the question, if you had 100% accountability for your bad experiences, would you care who was in control? What I hear from patients is probably not. Is it the right and good way for us to get more control over our health systems? Absolutely. But if we only focus on control and we don't create new levels of accountability or implement existing accountabilities, we won't actually achieve the change that we're trying to achieve. All we'll do is inherent systems and all of the bad things and blind spots that those systems have with them. A political process is a transfer of your individual rights to a representative body. A transformation process, on the other hand, is a manifestation of your rights into a system. If you find that change isn't happening fast enough, what I've noticed across 2 decades of work in this area is that we probably aren't doing enough transformative processes, or we're labeling transformative processes when they're actually political processes, both of which have to happen. Both are extremely important, but one without the other is ineffective. Changes in control reorganize risk in a system, but they don't change the balance of who holds the risk. If we actually want to protect patients, we have to allow patients to manifest their rights. For Indigenous patients, that includes making sure that Indigenous patients understand that they have control over their healthcare personally, that they have a right to get a second opinion, they have a right to receive access for common medical conditions, they have the right to the same things that people who are protected under Health and Safety Acts have, even though they're remote. These are all choices that we make in order to manage risk within health systems. If we don't provide health to Indigenous people within Saskatchewan, that's almost a 20% discount on costs. Have you ever thought about that? 1 in 5 people in Saskatchewan are Indigenous. If we don't provide care to those 1 in 5 people, we save 20% of healthcare costs. If people come for care and are denied care, that's cost savings. That's managing financial risk. If someone comes to report and we act to them in a hostile way, that's us managing litigation. If we're not willing to sit down and hear your actual experiences, we're managing our own emotional fragility as physicians. Truth has to come before reconciliation. And the truth really lies in patient stories. Thank you.
On behalf of the Wîcihitowin Committee, please accept this small token of our appreciation for everything that you shared with us and for accepting the invitation to come. Ladies and gentlemen, Dr. Alika Lafontaine.